Hi guys, this is Jody, and now we're going to talk about peripheral vascular disease under the umbrella of the concept of perfusion. Just a very quick overview. We're going to talk about two things when we talk about peripheral vascular disease. There's venous disease and there's arterial disease. When we talk about chronic venous insufficiency, it's inadequate venous return over a prolonged period of time. So just remember that veins carry the blood from the peripheral tissues, or from the peripheral body back to the heart. If that can't happen, you have blood that can pool in the lower extremities, and you'll get this stasis of blood. If it's more severe, that patient will likely develop some edema when their legs are dependent, when they stand for long periods of time or they're sitting and their legs are dependent. The most common cause of venous insufficiency is going to be a deep vein thrombosis. And these can develop in fairly young people as well as in older people. If you have a young person who, for example, not that my husband is really young, but he had a friend, when his friend was in his 40s, he went on a very long plane trip, and his friend was, I think he's well over 6 feet tall, and of course sitting in coach in an airplane, you don't have a lot of room to move. So he was sitting very still for several hours, and when he got to his destination, he had pain in his leg. He went in and got evaluated, and he had developed a blood clot. It is a circulation disorder. You have impaired blood supply to the peripheral tissues. There's arterial sclerosis, which is chronic arterial disease, and then you have atherosclerosis, which is the obstruction and hardening of the arteries from that plaque buildup. So pathophysiology and etiology. Well, you guys looked at these vessels when we talked about coronary artery disease. You see the vessel on the left here. There's a nice opening. It's nice and clean. The blood can flow through here easily. When you have plaque buildup over here on the right, you have a narrowing and what they call sometimes hardening of the arteries. And the blood is going to have a harder time traveling through here. So you can have either, a complete obstruction or decreased blood flow. This can lead to tissue hypoxia or anoxia. This venous stasis causes the blood to stagnate in the lower extremities, and like I said, that can lead to some edema. You can have increased pressure, which impairs the arterial circulation. So you can have patients too that have a combination of both venous insufficiency and arterial disease. If it's really bad and the tissue isn't getting the perfusion it needs, it's going to lead to tissue death. Patient can develop ulcers. They can either be venous ulcers or arterial ulcers, and we'll take a look at those. And if the circulation is not improved, these wounds are going to get worse and they're not going to heal. So I have had patients in the past who have had what we call chronic ulcers. We try to do what we can to promote perfusion. That might be through angioplasty, but if we can't get the blood flow to those tissues, we're not going to heal those ulcers. And you guys should know that when a patient has wounds of any kind, we should be instructing them to increase their protein intake because that will help heal their wounds. Risk factors. So men are affected more than women. Older adults generally over 80 are at a higher risk, or you'll see it in individuals over 80, but people are at increased risk over the age of 50, and African Americans are at increased risk. You increase your risk through smoking, hypertension, high cholesterol, diabetes, family history, obesity, inactivity, and prolonged sitting and standing. When we teach prevention, we want to teach patients to maintain a healthy weight, healthy diet, so that's low fat, low cholesterol, low sodium, that heart-healthy diet. If they do have wounds because of their venous insufficiency or arterial disease, we want to increase their protein intake. Regular exercise, management of chronic illnesses, and blood pressure and cholesterol screenings. Clinical manifestations include pain, intermittent claudication. So intermittent claudication is pain when the patient is up and walking. It's generally an aching pain that happens in their calves. It can also be in their thighs or buttocks, and it's relieved with rest. So this isn't a pain that they necessarily have to be taking pain medication for. So if the patient has peripheral vascular disease, they have this intermittent claudication, you would instruct them to walk, and when they feel uncomfortable or they have this pain, to rest. We don't want them to be sedentary, though. We do want them up and moving. So walk until you feel uncomfortable and then rest. They may have rest pain, which increases with elevation and decreases when the legs are dependent. Decreased or absent peripheral pulses, bruise over large affected arteries. Legs will be pale when elevated, dark red when dependent. Skin is thin, shiny, hairless, discolored because the tissue is not getting the perfusion that it needs. They usually have some thick toenails, tissue breakdown, and in more severe cases you'll see that edema. So arterial versus venous ulcers. So just remember with arterial, they look like they're punched out. They're very smooth looking around the edges, and they're generally a little paler in color. Venous are going to be irregularly shaped and more shallow. So through collaboration, we want to slow the process of the disease, maintain tissue perfusion, pain relief. We want to heal any wounds that might be present, reduce the edema, and specialized wound care, which usually includes this Unaboot. So it's a wrap, as you can see in the image. Some home care nurses will do this in the home. A lot of times it's vascular that will do the dressing changes. You want to be very careful with compression. So even though patients may have edema, we don't necessarily want to put a lot of compression on these patients, because if they have arterial disease and we compress those arteries even more, we're going to decrease perfusion down to the tissue. So while compression helps with venous and it helps push that blood back up to the heart, if that patient has arterial disease, blood flow is going to have a harder time getting down. So what they usually want to do, say a patient has a wound, maybe they can tell it's a venous ulcer. That's what vascular diagnoses it as, is a venous ulcer, and they want to try compression. Well, the patient may also have some arterial disease. So before they put compression on this patient, they're going to want to do an ankle brachial index. This is a quick, non-invasive way to check for peripheral arterial disease. Some nurses are certified to do this. There's really nothing to it. It's basically you're checking blood pressure in the ankle and a blood pressure in the arm, and you're looking at the difference. And then the vascular doc will determine whether or not it would be safe to use compression on this patient. It's also a way to diagnose or help diagnose arterial disease. So again, with diagnostic tests, you have the ankle brachial index. Stress testing is more used to test for cardiovascular illness. So if we know they have vascular disease, we want to be looking at that as well. Doppler ultrasound to listen to the blood flow, and then angiography. And we know with angiography, what they're doing is they're sticking that wire through, and then they can do some ballooning to push that plaque to the vessel wall and put a stent in if they need to open up that vessel so that blood can flow easier. So treatments, again, non-invasive would be antiplatelet therapy, so aspirin, clopidogrel. Exercise, so we want them to be up and moving, but rest when the pain occurs and resume when the pain resolves. Avoid elastic stockings, they can reduce circulation. But again, with wound care, compression usually helps with wound healing. So don't be surprised if you see a patient with some venous insufficiency and they have a wound, and the doc will put a little bit of compression on to help heal the wounds. But again, they would do the ankle brachial index first. So don't feel like you would ever go and just willy-nilly put compression on a patient with peripheral vascular disease. You would not. But don't be surprised if you do see, the vascular doc orders some compression for wound healing, because they may do that. So just be conscious of that. Invasive would be that stent placement or the endarterectomy where they're removing the plaque, or the bypass graft where they're going to try and find like a detour for the blood. Nursing process, so assessment and interview, observe for pain in relation to exercise or rest, edema, skin discoloration, ulcers, that history of coronary artery disease, hyperlipidemia, hypertension, diabetes, diet, and exercise. Look at their vital signs, pulses, cap refill. Cap refill may be sluggish. Skin color, it's usually going to be pale if their legs are up, and then maybe they have a deep ruddy color to them when their legs are dependent. They can have some staining on the skin. Hair distribution, again, they're not going to have good perfusion down there, so they may have like a shiny appearance on their legs, and they may not have hair on their legs, and look for wounds. So diagnosis, ineffective tissue perfusion, chronic pain, impaired skin integrity, activity intolerance. So your planning would be smoking cessation if they're smokers. We want to reduce their risk factors. Skin and wound care, medication adherence, and activity and exercise is tolerated. So interventions, elevate extremities or dangle extremities. And I have a slide on the next one. This is important to remember. If the patient has venous insufficiency, the blood is having a hard time getting from the lower extremities back to the heart. So we want to help that out with gravity. So with somebody with venous insufficiency, we would get them up in bed and elevate their lower extremities, and that should help. If they have arterial disease, the blood is having a hard time getting from the heart to the lower extremities, so they may be more comfortable sitting at the side of the bed and dangling their legs, because we're going to go with gravity. Either or, you're going to keep the extremities warm, because keeping the extremities warm vasodilates so that blood can flow more easily. Instruct them to avoid crossing their legs. Okay, that impacts perfusion. Actually, it's not good for anybody. Nobody should be crossing their legs. Position changes to promote blood flow. Again, so this is elevate if they have venous disease, and dangle their lower extremities if they have arterial disease. Mark pulse locations. Be nice to yourself and your fellow nurses. So it's very common that you won't be able to palpate a pulse. Like, you might not be able to feel a pedal pulse on these patients. Their feet might be cool, can't feel anything. So you're going to get out your Doppler and you're going to listen for blood flow. And when you find that spot, you want to mark it with an X, so when the next nurse comes in to do their assessment, they know exactly where to put that Doppler. Pain management. So again, if they're having that intermittent claudication, have them rest when they have pain and ambulate when they feel okay. Skin care. Moisturize the skin. Okay, we want to prevent skin breakdown, so making sure that they're up and active. If they're more bedbound, we would want to be turning and positioning and putting a bed cradle on, which helps prevent the blankets from putting pressure on the lower extremities. But moisturize the skin, take care of the skin, skincare, very important. So I just want to talk about this again. So priority nursing interventions. So know the difference. If they have peripheral vascular disease, elevate. Elevate those legs. Go with the flow. Okay? And if they have arterial disease, you want to hang them or dangle them at the side of the bed. Evaluation. So always make sure that your goals and when you evaluate match up with your interventions. So if you taught the patient a smoking cessation program, the evaluation was client begins smoking cessation program. Okay, that would be goal met. If you taught exercise or an exercise program, the client begins the exercise program. If the client has wounds and you teach them to do wound care, then they would demonstrate wound care. That would be your goal, your outcome. And that is it. If you guys have questions, please come to my office hours or send me a message. Thanks.